Good morning and welcome to Everything Digital Health. I'm Marcus Baw. I'm a GP in Yorkshire. I'm your regular host for this YouTube channel, and I've got today with me Joe McDonald and Ade Byrne, and they're people who I'll allow themselves to introduce themselves, and we're going to talk about the Rewired 2025 Digital Health Rewired Conference, which took place last week, which I was unfortunately unable to go to. That's the first Rewired I've missed since it started. But Joe and Ade were there, and we're just going to chat through some of the things that they saw. So welcome, Joe and Ade. I think both of you have been introduced previously on the podcast, but if you want to say a few words just to introduce yourselves, and then if we go first, Joe.
Yeah, I'm Joe McDonald. I'm a consultant psychiatrist. Recently returned to the register to practice. Former national clinical lead for IT brackets mental health during the national programme for IT, and was once upon a time medical director of the Lorenzo delivery team, where we spent billions of pounds and got nothing to show for it after many years. That's probably enough from me.
Ade?
Yeah, I'm Ade Byrne. I'm an ex-NHS Chief Information Officer and also ex-chair of the National Network of Chief Information Officers, actually when Joe was chair of the Chief Clinical Information Officers Network. So we've had quite a long-term relationship, I suppose, 10 years or so.
That's pretty good going for any relationship.
Yeah.
So Rewired has become in the last 5-6 years a fixture of the digital health calendar. It's usually in March, and it's a combination of some conference content and some kind of trade show content, almost, isn't it? It's got two sort of different rooms, and so there's quite a variety of things going on. So given I wasn't there, do you want to tell me about what you saw? Do you want to go first, Joe?
Yeah, sure. Well, it was big. It was as big as eHealth Insider Live.
EHI Live.
EHI Live, yeah, it was as big as that. In a great big hall. You'll remember it, Marcus, from the olden days where the acoustics are really terrible, but some of the content is quite interesting. And there's a big old hall full of stands where everybody's selling their wares. And I thought what was interesting about it this year was there was some buzz about it, and there was some new stuff, and I was relieved to see that free beer is back in a number of areas. Towards the end of the day, free beer is back, and you know what that means? That means the vendors have got something to sell, and what they had to sell this year was largely AI. And there was a lot of interesting demonstrations, but there was a genuine buzz. There was free beer. Often the best bits of these kinds of shows are in the evening, and that was good. There was quite a bit of after show party, and yeah, I really enjoyed it. I don't know about you, Ade.
Yeah, it was a good show, I thought. I believe that the organisers are pleased with the attendance. So the last few IT shows that I've been to have been a bit flat, to be honest. So I thought the attendance was up, and that was good. The new owners, let's not forget that the ownership's changed. So the company was sold to a group called Closer Still, who I don't know much about, but I know they own a few of these kind of gigs. So it's their business and it's their core business. So, hopefully it's in good hands, but they'll be pleased, I think, with the asset that they've bought based on the attendance. And of course, like Joe says, the optimism around it. Interestingly, when it first went to Birmingham, I was one of those that went, oh, blimey, who wants to go, to sit out in a remote complex of exhibition halls. It isn't anywhere near anything. It's really stale. You're sitting in a hotel bar at night or something, and everything's expensive. But actually, in the last couple of years, the whole complex has really grown up, I think, and it's now a place that can truly host a good few hundred people, including keeping them happy after the show. So, I know that it's planned to be there again next year, and who knows what will happen after that. But I think the original plan was definitely to move it back into London. I don't know if that is nailed on, as in signed, but I would encourage anyone to carry on there now, really, having been there. I think it's kind of the perfect venue once you get into those numbers. So, yeah, it was good. There was a lot of talk about the NHS England and ICB and NHS budget and stuff, and all the news around that. I'm sure we'll come back to. People were optimistic. We've talked about why that is. I really don't know why that is. I put it down to the weather.
Hey, I thought there's something about being sequestered out on the outskirts of Birmingham, and the fact that you're kind of all lumped together in a small space. I think there's something about that actually works. Whereas in London, people tend to disperse, go do their own thing in their favourite pub, etc. None of us have got a favourite pub at Birmingham Airport. So I found myself able to meet with all the people that I wanted to meet with, because they were all kind of, come 5 o'clock, at a bit of a loose end and likely to be in the same place as you. So I think there's a little bit of magic in everybody being on the campus. It's a bit like summer school. There's nowhere else to go. Do you know what I mean? And you're thrown together
in conclave. You're all held together.
like Conclave. We've all watched Conclave recently, I guess. But
I guess. Yeah. I mean, when we were at Olympia, everybody at the end of the day used to fit in the hand and flower, didn't they? And that was great. The ones who were staying anyway, and didn't go too far. And then when we were in
Business Design Centre,
North London, and the Angel and the Design Centre, I felt that people did scatter to the four winds because there wasn't a really a focal point there. In Birmingham, there probably, there are one or two focal points. You don't move far from the whole entertainment complex anyway, do you? Let's face it. And there's a kind of a kettling that goes on then, isn't there? Into one place, at the end of the evening, anyone who's still up is in that one place. So, yeah. I mean,
I'm guessing the vendors like that.
Yeah, I guess
they like, because they know where their target market is, and they can buy them free beer.
Yeah, so I don't know. We probably shouldn't go on too much about the social side of it, although it's a big side of conference, I suppose. But the fact is, I initially started out as a bit of a detractor of the whole thing and the area, as in the NEC, and now probably would say for a big show, where else are you going to go?
Yeah, I mean these things evolve, don't they? And the social side of things is an important part of it, even though it might seem frivolous that we're talking about that. It's meant to be about digital health and tech, and it's very serious, and there's big money being spent in the NHS on this stuff. But the individual practitioners of this stuff are all part of a community that's quite small, and we meet up at these events, and it's quite nice to sort of see everybody and catch up and see what they're each working on and how things are going. Especially in challenging times. So, I mean, we haven't mentioned it today so far, but Ade and I did an episode about 10 days ago about the rather shock announcement that NHS England is going to be abolished, which came kind of in the same week as it was going to be reduced by 20%, then 50%, and then abolished completely. So that's kind of put the cat among the pigeons in the whole community. So it's quite nice to have a place where we can all get back together and sort of provide a bit of peer support, because I think there's a lot of people who work in the centre or get their funding stream from the centre or work in an ICB, and there's a huge amount of change happening. and there is talk of national redundancy package being set up so that they, rather than each trust having to do it themselves, which means that if they're doing that, then there's going to be a lot of redundancies, and that's putting people in fear of their jobs.
I spoke to quite a few worried souls from NHS England, who kind of swim up to you out of the crowd with a sort of Edward Monk, the Scream look about them, and worried about their paying their mortgages. And you've got to feel for them. But the advice I gave to several of them was that being defenestrated from the centre isn't always a bad thing. It happened to me. It happened to me 15 years ago or so, and actually, it was the start of something really good. And these people have got skills that have got them into positions. A lot of them have got clinical skills. By God, we need you back on the tools. So there's it's not the end of the world. Was my message to everybody I spoke to in that position, and far from being the end of the world, it might actually be the start of something really good, because being in the centre is a bit like banging your head on a brick wall. It's lovely when you stop, and I was trying to be encouraging to people who found themselves in that position. I also felt that some of the buzz around the event might have been actually just change. The fact that things might change, and we might get out of a groove that hasn't served us all that well in terms of, a diverse marketplace, and a culture which probably due for review / demolition.
Oh, definitely. I think looking at some of the reaction to the announcement, obviously there's the people who are in fear of their jobs, and that, I suppose, is worrying for them, and it's upsetting to see people who are worried. But looking at the bigger picture, there were some quite good comments I saw about this is essentially closing the chapter on the Lansley reforms. So Andrew Lansley originally was the health secretary in the sort of late 2000s, early 2010s kind of period, wasn't he? And that included the creation of this new commissioning body for England. And I think the thinking was that it was going to be around bringing us to some extent with parity with the devolved nations, because they had NHS Wales and NHS Scotland. So the idea was, great, we'll have NHS England. But all it seemed to have done is created endless bureaucracy between the Department of Health and Social Care and anybody who's delivering anything. And huge amounts of money is sort of flowing through NHS England. But in terms of additional leadership and doing the things that were needed to be done, including doing the hard work to make it simple and doing things nationally to save everybody repeating the same work locally, they weren't really showing enough leadership in those areas. Feels good that they've gone, to be honest. It feels like everyone's breathing a sigh of relief.
Oh, you've said that out loud, Marcus.
Yeah, I spent a lot of time in meetings with NHS England. I actually briefly worked for NHS England, very briefly. I worked at NHS Digital. I have taken my turn at the capstan, trying to push for change, and have tried to do it on the inside as well as on from the outside as a kind of revolutionary, and doing the change from the inside sounds like a good idea until you try and do it, and then, or as you say, it's banging your head against a brick wall. Very difficult to get buy-in to anything that's a new idea, even when the costs involved are trivial compared to the top line spend. So, I was invited to go and meet somebody at NHS England when I first got into informatics, and I was talking very seriously about building an open source GP clinical system. And all we were asking for was a frankly trivial amount of money. And we didn't get any interest at all after they'd re-procured the GP systems for that year. So I think what had happened is that we were being used as a kind of a human shield, as it were, or a threat. They can show the GP system suppliers that there's possibly an open source one coming along, so better knock a zero off the end of your quotes. And once they'd used that as leverage in the negotiations, they dropped us like a stone. So
same thing happened for a while with open source Office products, and people thought that we were going to use the likes of Libra or something instead of Microsoft, which
Yeah,
we
and
all know would have been difficult. But I think that it was something like that, and as soon as the deal was done, no one was using them anymore. One of the things that I feel that the NHS would be well advised to do would be to continue, like you say, a relatively modest investment fund into some small projects that could yield some of this one day, and maybe you turn around and say, look at this, it's fantastic. Or maybe, you never do. It just carries on being something of interest, but it's just because it never actually deploys to, a million people doesn't necessarily mean it wasn't worth doing for the NHS, I think, to keep
so
those
Ade,
things going.
I was a founding director of Aperta, which was also a decoy, I think, in a negotiation with Microsoft and others, and a temporary experiment which very quickly ran out of steam and money. And I think there have been a few of these. Did you see Mike Bracken on Morning One at Rewired? Advocating actually that this is an opportunity with the abolition of NHS England, that there's an opportunity to rethink how we do the whole thing, and an opportunity possibly, for Tony Shannon and Ewan Davis's 1% fund, where they take 1% of the IT budget and just do something entirely different in a corner of the country, and see if you can regrow a marketplace that's become utterly stagnant.
Well,
And he
Mike
was,
set the tone for the whole conference, really, for me. I think that for myself, from that point forward, I was quite optimistic over the 2 days, and I think it was largely kicked off by what he was talking about. Some of those values that were espoused by NHSX, actually, which were open data platforms and not being locked into proprietary solutions, and it was all really refreshing.
why don't we just make him chief digital officer for the NHS then?
Well, you're not the first person to say that, Joe, and you won't be the last. It was, lots of people were saying that.
Yeah.
That's a
Well,
bit Trumpian, isn't it? So people are saying this guy should be, I don't know who they are, but people,
there was
people are
just so
saying he should be
much,
the chief digital officer.
common sense. You can't believe that he isn't.
Yeah.
Do you know what I mean? Let's focus on. Let's buy some British software. Madness.
Yeah.
Let's go for
It feels
growth.
like we've been on the bus to Abilene for 12
Well,
years since
what?
NHS England came along, and now we can finally get off the bus.
I guess
The Abilene
things,
paradox is something that I will link in the description, but we're going to do an episode on that, I think, in the future, aren't we, to talk about what we mean by that. But essentially, it's how people unwittingly fail to manage their agreement, and so they all agree to do something that is in none of their best interests. And you see this happening all over human society. But the guy who coined the term is a management consultant called Jerry Harvey, who does essentially 2 hours of stand-up where he talks about the Abilene paradox, and it's hilarious. I'll put the link in, but we definitely need to cover that at some point. So Rewired, what was good? What apart from the kind of general mood and the controversy that was going on at the time with NHS England, what did you see that made you think, okay, I'd like to see that in a clinic room near you?
Yeah. This is difficult because I work for the Access Group, and the AI scribe that they've put into Rio, which was being demonstrated on the stand all week. It's game changing. It's absolutely game changing. All the EPRs have got one, and I suspect they're all pretty much the same under the skin. But then the differentiator will be how well it's been integrated. But that for me was where a lot of the buzz was. My clinical colleagues are beyond excited about the fact that the drudgery is going to be taken out of most of what they do. And for the first time, I feel like the industry is not inflicting digital paper on clinicians. We're finally going to make life a bit easier for them. If you look at the results of the national UX surveys over the last few years, people are having a pretty terrible time in most places, and it's having a real effect on burning staff out. I think that's about to change. I think that might have been where some of the buzz was coming from. And the vendors all have something to sell now, hence the free beer, I think.
Yeah, so like it feels there's a bit of a rejuvenation in the marketplace because there's suddenly now an actual new feature as opposed to kind of same old bit. This button has moved to there, but apart from that, it's the same. AI.
I mean, trade shows were getting really boring. I mean, really dreadfully dull until this year, I think, where there's a genuine uplift in the tech, and a real prospect that life will get better as a result of the tech. I don't know what you think, Ade.
Well, certainly I agree with that part, Joe, for sure. It's a long time since I've been to a show and seen anything, genuinely new. It's all recycled stuff, isn't it? Quite refreshing that I wasn't wandering around just seeing people talk about nothing other than RPA, to be honest, which is my, pet hate, as you may know. But
that's bar staff, Ade.
that and bar staff who can't serve more than one person. Yeah. But yeah. I mean, there's something new in the air, isn't there? I worry about it a little bit that it's going to hit the buffers when it lands on top of the clinical safety regimes that we have and how they will take to some of this. And, they're right to be nervous about it, aren't they? So, I know that some things have already been deployed without sufficient underpinning safety work done on them. But, the fact is you can't blame a machine for anything. You can't take a machine to court. So what happens when, it fails to recognize something? And to date with artificial intelligence, we've used AI largely as an advisor, haven't we? So, you choose whether you take its advice or not. Now, if it's listening to your conversation and you're kind of expecting it to go off and, for example, order things, great, except what happens if it doesn't? And then what's the backstop on that? And, those things will happen, but you've got to make sure that you've done the safety work when you put it in to make sure you've at least done an element of due diligence around it all. And I worry that some of these things are just being, let out into the wild, as it were, without having that done. And, I worked in a hospital and we were fairly good on implementing regulation. Large organizations, I think, will tend to be quite good. So I would worry more about the smaller ones. I'd worry about what's going on in primary care with some of this.
Yeah. And so this is a great opportunity, really, to do some of the clinical safety work, medical device work nationally, do it once, do it well, and share it with the whole country, as opposed to having everybody in every single deployment situation repeating the same clinical safety questions that have already been answered and hopefully mitigated in other places. But I think just to sort of recap what we're talking about, so AI clinical assistants, as it were, are a tool that will listen to the ambient conversation in a consultation and will infer from that what the clinical entry in the notes should look like, kind of thing. It will create a summary and put it into some kind of form that you could say, this is my clinical entry in the notes that says what I discussed with the patient, what I decided to do, what they said, and that kind of stuff. And maybe it can be trained to base that on a template So what kind of things do we want to be in there? So people use systems like SOAP, subjective, objective, etc. Or SBAR or other frameworks for containing the information, and you can get it to output something that you could say, right, that goes straight in the EPR. And then similarly, you could get it to also output something that you could say, that's a letter to the patient copied to the GP about this clinic visit, sort of thing. So the potential there is to save clinicians a lot of time documenting, which they used to have to do quite longhand, typing into EPRs, and that's been recognized as a significant cause of burnout and a cause of dissatisfaction with their clinical work, really, because it would often, with a digital system, it would take longer to annotate your clinical encounter than it used to do on paper. And that used to mean you'd maybe spend, in a general practice situation, 15 minutes seeing the patient, but then it would take quite a long time to write it up. And general practice is the best case scenario, in that I think that the EPRs are very attuned to the situation, whereas secondary care EPRs could be much harder work. So it's potentially a game-changing advance in how we do medical encounters. What are some of the downsides that you think that this will bring with it? If we put aside the clinical safety stuff, or at least we could drill down into the clinical safety specifics, what are we worried about?
No, the first thing you worry about, I think, is that people stop thinking.
Follow the sat nav into the river.
Yeah, okay, that's a good analogy. Yeah, so if you got given your synopsis of the medical consultation that you've just had, and you just approve it without reading it, I guess is what that's the threat model. The worry
I
is
think
that
if you get very, very used to it, and if it gets very good, and to be honest, it's already very good. The temptation to just move on to your next patient and trust the machine will be quite huge. So, as a former medical director of a trust, you're used to reading the letters that the juniors are composing, because they need to be up to a certain standard. So you read the first 5 or 6 letters that the junior has written, discharge letters to the GP, for example, and then after that, if Dr. Johnny Newshoes has produced 5 good letters, I'm probably not checking the rest, and I worry that'll happen with the AI, because that's effectively a junior doctor writing up your consultations, and if it's pretty good, you'll pretty soon stop checking. So audits will become very important. The patient safety stuff, I think the big companies, who are producing these EPRs with inbuilt AI scribes, will be pretty good at the safety piece, but they will hand off the final bit of safety to the clinician.
I think there'll be a lot of that to say. I can imagine there being disclaimers actually that just say, this is AI. It can occasionally hallucinate and make up stuff that it didn't hear and isn't true about this patient. And you as the clinician are responsible for detecting that.
But
which is fine, actually.
it is.
There's a big difference here. We talked about this, I think, in the HIMSS episode, about if you've just had the consultation and you're presented with a synopsis of it, you quickly read through it much faster than you would be able to type it, then you can pick up those errors fairly quickly because it's fresh in your mind. And there's a big difference between that sort of AI deployment and AI being used to pick up, to formulate a discharge summary for a patient you've never met. And you're the doctor who on a Sunday evening has got to check this discharge summary so the patient can go home. That to me is a much more dangerous area, because you as the doctor in question can never really check all the facts because you weren't there. You don't know this patient. You weren't part of their care. You're taking responsibility for it. And this is maybe an area where we need to support the clinicians in being able to make categorical decisions about which kind of AI they can say yes to and which kind of AI they can robustly decline to sign off and say, I haven't had any involvement in this care. I'm not going to sign the AI letter.
But the other side of it is, if you are not increasing the productivity of clinicians by giving them these tools, How safe is it to be on a waiting list of 4 years in duration for a psychiatric appointment, which is not unusual nowadays? 4 years. How safe is
Yeah.
that?
Yeah,
Well, you
that's
always have the same arguments against digital systems, don't you? Let's look at the residual risk in the system, and that always tends to be overlooked. But once again, the problem is that people judge the digital systems with a different set of criteria, don't they? So, if a digital system makes a mistake, the whole world comes tumbling down on it. If a human makes a mistake, it's like, well, humans make mistakes. So
well, I would
you're
say
always
it's almost
judging the
the
two
opposite.
things.
In practice, though, it's the opposite of that, because if an individual human makes a mistake in someone's care, let's say it's involved in that human signed off a letter that was produced by an AI, and that goes out to the GP, and it's got some hallucinated false information. It's the doctor who will be hauled over the coals and potentially complained against. It might even become medical litigation. There can be a whole slew of consequences for that clinician. But the AI, and more importantly, the people who created the I think it's very unlikely they would ever suffer any consequences.
I think
Well,
that,
I mean, this is a new sort of world of ethics, isn't it? That we really haven't got into yet. When who created the AI? Does it have bias? There isn't nearly enough work being done on that kind of stuff yet, is there?
No, and with almost any other medical innovation, we'd have something like post-market surveillance going on. So I think if these things are to clinicians, if they appear to be ready for use, then they probably are. But we still need to have that post-market surveillance, so we're picking up the patterns of failure across the whole system. So where a particular failure mode may only happen once in one trust, but of course there's several hundred trusts, so it's happening several hundred times. But if it only happens once in any given trust, then the clinical safety officer at that trust probably won't detect it as a pattern. We need to have national surveillance of clinical safety in order to pick up patterns that are bigger than a single trust. We don't have that yet.
Yeah, the problem is, I think these things happen very, 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 very quickly to you. And, I've got one of those cars that self-drives itself a little bit. I won't mention what it is because some people would come around to my house and set fire to it. But
I think we all know what you've got.
It's a Nissan Leaf.
Yeah, it's not perfect, it's a terrible driver actually. But when I'm on the motorway and I just stick it in self-driving mode and it's telling me that I need to concentrate, am I concentrating as much as I used to? Absolutely not. Of course I'm not. I'm just drifting away thinking about other things because it's driving itself. And it might be a terrible driver, but it's never going to hit anything. That's the thing. The accident, the only accident it's going to cause is if it stands on the brakes and somebody runs into the back of it. That's the truth. But what happens to you is in your mind very quickly you start to rely on these things and not concentrate. That's the point, and that will happen to doctors. And I remember, you've probably seen Russ Branzel of Chime do his talk a few times, haven't you, Joe? He's dined out on a number of different scenarios, maybe once too often. But the driving car is one of his that he's been talking about for quite a long time. Which is, right now we're scared about cars driving themselves, but if you wind forward 50 years. People will be saying, "What? You really let humans drive those things?"
Yeah.
So that's probably where we're going with doctoring, isn't it?
Well, my worry is that we over-regulate and we over-safety, and we lose the productivity which is required to save the NHS from going under. And I would like to see everybody who's using AI indemnified centrally by the government with a no-fault compensation scheme.
That's it.
And so the doctor doesn't get bollocked, the innovators don't get bollocked, and we suck up some of the risk so that we can have the productivity revolution which is required if the NHS is going to cope. The NHS is doomed as currently configured by the demographics of the population. unless we find a better way to do it. And go further than no fault compensation for the AI messing up. Take the legal bill out altogether. No fault compensation for everybody, and everybody can stop practicing so bloody defensively. And that, everybody who gets a bump on the head gets a CT scan. It's nuts. And we need to do something about how inefficient we've made people.
Yeah, the point is, it is now coming very quickly. This, isn't it? That's the thing. I mean, it's probably there's a saying that's used in digital a lot, which is you probably overestimate what you can do in 5 years and underestimate what you can do in 10. And certainly with the AI, I think we're in the underestimation bit of what it's going to achieve now in the next short period. You can see it coming down the road like some kind of avalanche now. So yeah, so there was a lot of talk, and a lot of the stands, from 3M have rebranded themselves in health called Solventum now. That's quite big news. They unveiled their new branding there, green branding, Solventum. Like most people nowadays, when they invent a new thing, seem to invent a word along with it. So
Yeah,
3M is now something else.
Solventum.
Yeah,
Can you abuse Solventum? Does it cause brain damage?
I have no idea, but it's. I mean, they
and what
they
have Emis
actually
now?
they
Emis,
were the
Emis was the big
first
shout on day
company.
one, wasn't it?
Sorry,
Emis was big news on day one, rebranded.
it was, except they kept it kind of under wraps because they had the attempt on their the United Healthcare assassination attempt on their chief exec, didn't they? So they were very nervous about doing any big showy thing. I think that's what I heard. Anyway, I didn't
They had
actually speak
balloons
to them
though. They had balloons
personally.
and
I
a
did see
lovely
the
orange,
balloon.
a lovely
So
orange
there's
yeah,
stand.
other brands, all the stands were talking about AI. Well, a lot of them were. What else? I think, the NHS England people were quite scripted, I thought, and that's understandable. There's FDP, which we're not going to talk about in any detail, but it's quite clear that the FDP has gained enough support amongst the board at NHS England, etc., that is going to continue. There's no chance that the rug's going to be pulled on that. There are a number of speakers on FDP, so there's a lot of interest in that area.
The federated data platform, isn't it?
Sorry,
so I will I'll bring that back in some future episodes because I think there's a whole load to unpack around that. But I think today we decided we'd just focus in on Rewired. So the EMIS story, just going back to that. So the EMIS is a prominent GP system with about 50% market share in England, and they've rebranded to Optum. Is that right? And they're it's an interesting move, really, because EMIS is one of the real stalwarts of general practice. Been around since the early days when it was a kind of green screen application, and it's gone through 4 iterations to go to a sort of terminal-based thing, and then EMIS PCS, and then EMIS Web, and now it's called Optum, which in some ways seems a bit of a betrayal of 40 years of brand loyalty. On the other hand, it might let them step away from what they are now known for, which is to some extent unreliability. I mean, I don't think
maybe Optum won't fall over.
Exactly. I mean, Monday morning Optum failure.
I remember when the nuclear power plant in the Lake District,
Sellafield or somewhere.
Sellafield, but what was it called before Sellafield? Windscale. And then they had a big nuclear accident and they renamed it Sellafield, didn't they? And radiation became magic moonbeams. And it was still exactly the same facility, doing exactly the same thing. But the rebrand allowed them to consign their disaster to history to some extent. And I suspect there's an element of that in the EMIS rebrand.
I remember when they rebranded Mr. Dog, Caesar dog food. I couldn't see anything wrong with Mr. Dog.
You need to see the Eddie Izzard sketch on Caesar. So was there any evidence of GP systems bringing an AI ambient assistant into play? Because they have historically been ahead of the curve. If you asked me 15 years ago the difference between primary care and secondary care, that primary care had functioning computer systems. But I don't think they're still ahead now. I think they've fallen way behind, and I'm not aware of any moves in the
There's a
area to
product
bring
called
those kind of
Heidi.
things.
There's one called Heidi that they're using quite a bit in primary care, but I'm not acquainted
But
with it.
that's something that's separate from the core GP system. And as Joe was saying before, the differentiator of all these things will be how well integrated they are. So it's no good me having a Heidi app on my phone, having to NHS mail myself the text of the thing and copy and paste it into EMIS or TPP as a GP. I want it right there in the system as a core feature of the core GP system, because it's only that way that will allow it to do any of the sort of further actions. Because writing the notes is only one thing. The next thing I want it to do is suggest for me appropriate read codes that I should be including. And then I also want it to be able to maybe even suggest what I should prescribe based on guidance. That's where the future is going to be.
Technology, yeah, a lot of the technology you see in health is what you could call legacy, isn't it? And that, the primary care systems that are in play, the two dominant ones in the country have been around, for so long that they can't be anything else but legacy, can they? They haven't been rewritten, replatformed, have they? They're legacy. A lot of the old electronic medical record systems are also legacy. Ultimately, this is where they will hit the end of the road, and this is where they'll run out of runway. They won't be able to sustain the levels of integration required to live with this new technology, will they? And that's what will kill them in the end. That's my prediction.
Yeah. Interesting. That's a good one. And we'll see how that pans out. I think you might be right, actually. I think that's...
I mean, the other thing, Marcus, is that, there are a number of standalone scribing solutions out there which I think offer enough on their own, outside your EPR, even if you're copying and pasting the output at the end. Some of them are good enough that, doctors will buy them with their own money to make life a bit easier. And that was always my fantasy with the EPR. Could anybody make an EPR good enough for me to spend a month's salary on it, out of my own pocket? And, I think
that's great. I think it's great as a marker of when it's got good to say, when would clinicians actually pay money for this? But the reality of working in the NHS is that we're talking about IT solutions. And if a clinician, even in a general practice, which, ostensibly general practices are independent businesses, they don't really run and own their own software and computers anymore. That's always outsourced to, it comes via the CSU, or it comes via the ICS, and somebody else owns the hardware and somebody else has put the software on it. And if you, as a GP, decided to install something new on there, I can imagine things not going well for you. Bringing your own device is often not an option, especially if you want it to be integrated, because you can have your own device, but if that's your personal phone or even a work phone, then there's information governance threads that now attach to that phone. And I would love to see this solved.
The security products that we deploy as an enterprise, if you start having those deployed onto your own personal device, just makes it unusable. You wouldn't want it. I don't know if you've had the joys of the Microsoft Intune stuff deployed on your own phone, and you can't even cut and paste between an email and a noting application or something because the computer says no, which you can understand if you're in the office, but it's bloody annoying if it's your own phone.
No. That's definitely not where we want to be. But I want to see this solved. I do like the idea that as a clinician, if you believe in a solution enough that you would pay your own money for it, not necessarily that you should have to, but if you did and wanted to, you should be able to do it. But I think that the way that we've got the IT infrastructure deployed in the NHS, you'd be prevented from installing new things. I've even seen recently something about clinicians being told that they must not use, their own ambient AI stuff, because I think for fair enough reasons that, you're bringing in some clinical risk that we've alluded to already into an organization that has not been given the opportunity to address that clinical risk. But how do we, maybe this is another episode, but we're going to have to solve this somehow.
Yeah, I mean, you don't know where these cloud services are. They're highly likely to be offshore somewhere, aren't they? So that's if you're talking about clinical and personal data, you're probably breaching the basic data protection rules apart from anything else. There is another use, of course, for this stuff, which is just using ambient voice to record and minute meetings. I mean, it depends how sensitive you are about some of the stuff that's said in meetings, and that's corporate detail rather than anything else usually. But there is definitely a use case for this stuff in, cutting out a lot of wasted PA time just sitting there listening to meetings.
Yeah, absolutely.
Maybe we should have less meetings though. Get Doge in.
Well, I'm a big fan of doing things in meetings, not just talking. But if the opportunity arises, I'll say, oh, right, so you've got everybody in the room in this meeting to write this particular document that we've all said needs to be written. So rather than one person taking that as a task to do afterwards, let's do it now. And I open the Google Doc and share the screen and say, there's the link. You can all start typing now. And the looks of horror that you get when you actually suggest doing something as opposed to sort of sitting and drinking coffee can cause a bit of consternation. So
no wonder you got defenestrated from NHS England, Marcus.
Oh yeah, well, I defenestrated myself actually. I climbed down a rope out of a window because I felt they were wasting my time.
Maybe you could have a meeting about doing stuff in meetings.
Yeah, you could create a policy about it, even, or a strategy, even better. I think that would be a great point. We could finish. Would love to have you back on and talk about some of the more detail around this. I think definitely AI is here to stay. I think that's what we're hearing, and there are some legitimate concerns that we have around it, but I think they can be addressed. What we need to do is have a mature and joined up approach, and maybe that's clinical negligence schemes and things like that, CNST and other stuff that protects people from the potential of harm through the AI. There are many solutions to this. I think we possibly need to unpack those in another episode where we go real deep dive into AI, the good and the bad and the ugly. But I think for today, thank you for being on the channel, and I will chat to you soon, I hope.